Hi, this is Brian Wormers recording a lecture for the care of the patients with urinary problems, specifically infection and non-infectious disorders, for medical surgical nursing at the University of Sioux Falls. Learning objectives are going to include assessing patients for actual or potential risks related to UTIs. We're going to talk about diagnostic testing for suspected or actual UTIs. We'll talk about, discuss, and prioritize nursing interventions for people with suspected UTIs. And we'll look at manifestations of different types of incontinence. And then finally, we're going to talk about non-infectious etiologies such as incontinence and urolithiasis. So infectious urinary disorders, so UTI. So this can be anywhere along that urinary pathway. Most of the time it is an ascending in nature, and it tends to go up and towards the kidneys. 90% of these is caused by E. coli, but other signs and symptoms can be with remembered with the 6pp pneumonic. I don't expect you to remember that one, but it's like Enterococcus, Klebsiella, Serratia, Proteus, Pseudomonas, and those type of things. The big one I do want you to remember though is E. coli, because it is far and away the one bacteria that causes most of the UTIs. So catheterization, of course, is a major concern with this, with 1 in 3 patients getting a UTI that have had a catheter. Complications can be life-threatening, so depending on where it's at is how we name it. Risk factors for UTIs can include sexual activity, diabetes mellitus, poor hygiene, estrogen deficiency, recent catheterizations, subjectively, so they might say that they've got frequency, urgency, or dysuria when they void. The urine might be cloudy or foul smelling. There might be blood tinge in that urine. There might be some pain, fullness, fevers, chills, nausea, vomiting, flank pain. Elderly, you see loss of appetite, confusion, and even falls. Objectively, so what we might see is urine samples. They should do this before you do your assessment. It does help with palpation, but they might have fevers, tachycardia, tachypnea, and hypotension. You might see some abdominal pain and distension with this, and they might have discharge. And it could be vaginal, or it could be discharge from the penis as well. Laboratory assessment, so clean catch, we talked about that. Get a culture for the infectious organism. Oftentimes it's E. coli. Looking for a left shift with the serum WBCs. We'll do an ultrasound or CT to look for any outflow tract obstructions with this. Or possibly we could use cystoscopy. Planning and implementation, so we're going to do optimal urine elimination with this. So using a wide variety of different things, including antibiotics, such as macrobid or Bactrim, try to treat the UTI. If they have any spasmodic with this, we can give medications to decrease that. If they've got a lot of pain, of course, we can give medications for pain. And then, of course, we're going to watch fluid output. Cranberry juice has been listed as being helpful against UTIs. With that, there's a couple of different reasons. Number one, it turns the urine more acidic when it's got to be real cranberry juice. It's not like just cranberry margaritas. But with that, it's got to be the real stuff and turning it into an acidic environment. The other thing that I think is if you're pounding the cranberry juice, you're increasing fluids. And when you increase the fluids, you're helping wash that out of your system. So, other thing we do is avoid irritants. So not that an irritant will necessarily cause a UTI, but it causes redness, irritation, and discomfort. Health promotion wise, so we really need to reduce the number of indwelling catheters with this. That's why we're trying to do different things, such as condom catheters or different stuff like that, or trying not to put a catheter in anybody that doesn't necessarily need it. When we put catheters in, we tend to be very strict on our sterile technique. We want to push fluids and make sure that they've got good urine output. Clean that site as well as possible, avoiding any irritants or scented products with that. We want to avoid before and after intercourse. They don't want to delay any urination with us. Nurses are really bad at this because, number one, we have long shifts. We tend not to go to the bathroom as much as what we should, and part of that is because we don't drink as much as what we should. So we are not increasing fluid intakes, we're not urinating well, and it puts nurses at increased risk for urinary infection. Tied with that, if we have this, we should have prompt treatment. That way it doesn't ascend up and get more difficult to treat. Alternative therapies, we talked about cranberry juice, or these other things. I've heard more about the cranberry juice than these others. I haven't seen any literature on apple cider vinegar, vitamin D. And topical estrogen is used for other situations, but I haven't heard it used for a urinary tract infection. Incontinence, a couple of different things that can go on with this. It's not always a normal process. A lot of people would just like to believe that it is related to aging or childbirth. With this, we can have different types. So stress incontinence is probably the most common. Patients cannot tighten that urethra and then they leak small volumes. Urge incontinence, so they suppress that signal to the point that they don't feel it anymore, and then when they do go, then they just have to release. Overflow, so the muscle fails to contract, bladder overdistends, and causes complications that way. And then finally, functional. There's just other factors that lead into this where they cannot, control their urine. Subjective, so a lot of screening questions are often needed with this one to fully understand the problem. They might have a full abdomen. They might have problems with their urethra, uterus, bladder, all these different types of situations. So to look at some of these prolapses and stuff like that, a rectal exam might be necessary to do. Not usually the nurse's responsibility for this one, but know that it might be done. Diagnostic-wise, so UA to rule out for any infections, and then of course looking more for structural abnormalities using ultrasound, CT, or even MRI. Planning and implementation, so with stress urinary incontinence, so there's a couple of different things we can do for this weak pelvic muscle. Try to do Kegel exercises with this. We can do cone therapy, and that's kind of a weighted Kegel exercise. We can do nutritional therapy, trying to avoid any irritants that might cause them complications and make sure that they're getting enough fluids. Drug therapies, so we can use hormones and estrogen or antispasmodics. Other things we do is pessary. So with this pessary, it's kind of a plastic or a silicone device that gets inserted and then it stops prolapses from happening. Otherwise, if this is a continuing thing, so surgery and correcting that surgically is an option. With reflex urinary incontinence, related to neurological impairment, so we might see this with people that are having head traumas or different things like that. Voiding frequently, emptying that bladder frequently, trying to keep smaller volumes will help with this one. Intervention-wise, we can do bladder decompressions with catheterizations if we absolutely have to, but realize that that has its own risk factors for UTIs as well. Urolithiasis, so this is kidney stones, and so with this, there's a couple of different reasons why this can happen. It could be related to high volumes of some of the calcium and other things that can make these stones. Other aspects of it would be poor fluid intake, acid-base imbalances, so having a very environment where these stones will grow. Tends to happen more in white, older, obese, diabetic, patients with gout, and a patient with family history of this. This can cause a lot of kidney damage, as you can see in this picture. It is not smooth and round and going to go through very easily. It's rough, jagged, it's causing scarring, and it hurts, supposedly. Subjectively, so they might say they've got a family history of having stones, they've got a lot of pain, renal colic, nausea, vomiting, and changes in pallor. They might have changes in urine, and if they they have decreased or no urine, that's an emergency because you got blockage, and that blockage is going to back up through the whole system and possibly cause problems to your kidneys. Objectively, they might look pale, ashen, or diaphoretic. Their abdomen might be kind of full or distended. And so diagnostics, what we'll do with this, so UA, WBC for any sort of infection, and then imaging with KUB, which is abdominal flat plate X-ray, a CT, or ultrasound. So as they have a risk for infection, so of course we're going to give drugs to manage pain, as well as drugs to possibly break up some of these stones if possible. We can do lithotripsy, so if you click on this link right here, you're going to see what that is, but it's using sound waves to break up the stones and so that the patient can excrete them. We can go up there with a scope and do that, otherwise we can do open surgical procedures to go in and grab the stone and remove it physically. Education for this, so really we want to do education on what this is going to look like, what this could signs and symptoms if this occurs, as well as preventative measures with like pushing fluids, taking any medications to treat hypercalciuria, medications to treat hyperuricemia or gout, and then nutritional dependent on the type of the stone. So if they're high in calcium, then we might want to drop that calcium level down a little bit. So, and then of course, always increased physical activity is always good for everybody, I think. Alright, that concludes this lecture. If you have any questions, feel free to contact me.